Hi, welcome, and thank you for listening to my presentation. This is a critical review of a cohort study, Improving Prediction of Depression for Post-Stroke Patients. My original clinical question was, in post-stroke patients, does the use of a depression screening tool prior to discharge from an acute care hospital eliminate or better control depression compared with no depression screening tool used within 6 months post-discharge? When I started looking into different studies and research on this question, I learned that in the acute care setting, there really isn't enough time for a diagnosis of depression. Because for depression to develop, there needs to be at least 2 weeks of the depression symptoms before it can be diagnosed. And with acute care discharges being done so quickly, there really isn't enough time for that. And then I saw that there were some studies being done on a prediction tool, which seemed much more appropriate for the acute care setting. So researching this kind of changed the direction of my clinical question to something that was more appropriate for the acute care setting. The study is Improving Prediction of Depression for Post-Stroke Patients. The search terms that were used were depression prediction, screening tool, and stroke. The database that was used was CINAHL, and the level of evidence is a level 4. This was a multi-center cohort study that took place in 3 hospitals in the Netherlands. It was a longitudinal quantitative study that assessed for the outcome of stroke or the outcome of depression in post-stroke patients over a 6 to 8 week period. In this study, 1,033 admitted stroke patients were approached for inclusion. The patients involved were diagnosed with either ischemic or hemorrhagic stroke, and the patients that were excluded were the ones that were shown to have serious cognitive disorders. This was assessed using a mini mental state examination, which is a 12-question cognitive assessment. Patients with a score of greater than or equal to 18 were excluded. Patients were also assessed for communication disorders. They all completed the French aphasia screening test, which is a test that can be completed in 3 to 10 minutes and can be conducted by a non-specialist with accurate results. Those who did not meet the inclusion criteria or who refused were excluded from the study. The researchers do note that in this study, most of those who were excluded was due to the fact that they were too ill. Data on the potential risk factors were collected on all those participating. This included data on socio-demographic and stroke-related factors, medical history with concerns for vascular risk, and depression, as well as other psychiatric disorders. Functional status was also assessed using the Barthel Index, which assesses 10 aspects of ADLs and mobility. Those who were included in the study were assessed for a diagnosis of major depression disorder between the 6th and the 8th week after stroke. The researchers used a trained lay interviewer using the Composite International Diagnostic Interview, or CIDI. The reliability and the interrelator reliability were measured and found to be accurate as well as the test retest reliability. They were validated using the Cohen-Kappa, which is commonly used to give a statistical measurement of interrater reliability. Generally, anything above a Cohen-Kappa score of 0.81 is considered very accurate, and this study had a Cohen-Kappa score of 0.84 for interrater reliability and 0.90 for the test-retest reliability, showing both to be quite reliable. A predictor scale was created by multiple logistic regression and backwards elimination. The results were verified by using an internally validated bootstrap sample to help prevent any bias in reporting. Bootstrapping is random sampling with replacement that can help measure the accuracy. And the items that were shown to have the greatest significance in predicting based on their p-value and the 95% confidence interval were used to create a prediction scale that they named the Dupré. This scored according to each predictor's correlation to the outcome of major depression. It includes a medical history of depression or other psychiatric disorders, a medical history of hypertension, a medical history of angina pectoris, and to what extent the patient needs help with dressing. The Dupre was then used on the actual patient data, and the accuracy of the scale was assessed. Out of the 382 patients in this study, 54, which was 14.1% of them, developed depression symptoms and were diagnosed with post-stroke depression using the standard criteria. When comparing the stroke patients that tested positive on the predictor scale with the 54 patients that were later diagnosed with post-stroke depression, there was a sensitivity of 0.73, which fell into the 95% confidence interval. A confidence interval of 95% means that the prediction scale should accurately predict a post-stroke depression diagnosis 95% of the time. When comparing those that were negative on the prediction scale to the outcomes of those that did not meet the criteria for a depression diagnosis, there was a specificity of 0.75, which was also a 95% confidence interval. Specificity is the probability of showing no prediction of depression when there was later no diagnosis made for depression. Appraisal of the study was done using the critical appraisal of cohort studies, which addresses the validity, which are the results of the study obtained through sufficient scientific method, and reliability. Do the results have sufficient influence on practice, clinically and statistically? When looking at the validity, we looked at was there a well-defined patient population at a similar point in this disease? For this study, yes, there was. The patients were all assessed during the first week post-stroke that they were in the acute care setting. And then the follow-up was done at the same time. So the population was at the same place during each study. Was the follow-up sufficient? 6 to 8 weeks were allowed for the diagnosis of depression to be made. So they did give sufficient time for the development of post-stroke depression, but also did it in a timely manner so that they didn't wait too long for that diagnosis to be made, as depression can have significant impact on rehabilitation, so that we didn't want to let it go too long either. Was the study unbiased? There was concern for bias in the study because they're trying to create their own prediction scale. However, they did do extensive research and testing to find the most significant prediction factors and then tested for the reliability of those results. So the prediction scale has good reliability and validity, but it's only been tested in this one study. Did the analysis adjust for important prognostic risk factors? They did not include the more ill patients that were part of this population because the depression diagnostic test could not be used on them, which definitely affected the numbers. Those that are less affected might have a different risk factors and might be less likely to become depressed than those who are more ill. They tested the most common risk factors as well that had already been looked at and added a couple of their own and tested them. So they did use what were already known as good predictors and were able to find the most influential risk factors. Reliability. What is the relationship between the predictors and the outcome? When comparing the stroke patients that tested positive on the predictor scale compared to those who were later diagnosed with post-stroke depression, it did fall into the 95% confidence interval in the prediction. So there seemed to be a very strong correlation between the prediction and the outcomes. And how precise are the study estimates? The items that were shown to have the greatest significance in predicting based on their p-value and their confidence interval were used to create this prediction scale. So they were pretty precise. They used the ones that had the strongest influence on the strongest correlation to the outcome of major depression. Strengths and weaknesses. For their strengths, they had consistency in testing. They used the same individual testing on many of these patients. They checked for inter-rater reliability. They did retest consistently. So this did show a lot of reliability in this. They also did a lot of research prior to the study. Research was done to see what had been assessed so far, what were potential predicting factors, and what was easy to use that a caregiver can use in the acute care setting. And they used this to predict, or to do their study and use some reliable predictions. Limitations. There was no power analysis done on this study, so we don't exactly know the amount of patients that was needed to give us accurate data. The population could have been too small, or it could have been too large for this type of study, which can skew the data, and we really just don't know where we fell on that. The study does not include the entire post-stroke population. It did not include those that had cognitive or speech disabilities, who are potentially more at risk for depression. So this limits the amount of post-stroke patients that we can actually help. Of course, potentially a different prediction scale will actually be needed for these two different populations. The more ill just may need to have a separate prediction scale compared to the less affected population. They also did not register medication use. The researchers did not document which patients were on medications and what those medications were, and this could definitely affect the outcomes. For example, patients who have hypertension but are on medications that fully control it may have a lower risk than those who are not taking medications and who are out of control. So this affects the predictions on this scale. There's also no documentation of those who are on antidepressants or medications that can decrease the risk of depression. This could also decrease their potential of being diagnosed with post-stroke depression. So not addressing this could have very strongly affected the outcome. Patient care. Is this ready to become evidence-based practice? No, I'd say more testing definitely needs to be done on this prediction scale. It was just done on this one cohort study and was created on this study. So we definitely need to do more cohort studies, and then probably a systematic review, bringing all of those together to really show that this needs to become an evidence-based practice before we can put that into place. However, that being said, this definitely teaches us of potential risk factors for depression and gives us the ability to teach our patients, which essentially really empowers our patients. It gives them the information. They're going to know what the risk factors are. They're going to know what the signs and symptoms are, and we're putting the power back in their own hands to take control of their own care. They can notify their physicians when they see the signs and symptoms, and this in fact may actually increase our population being diagnosed with depression because the patients are going to be aware of it. They're going to see when there's a problem, and they're going to follow up and take care of this issue. For recommendations, like I said previously, there needs to be more cohort studies done. This one test is just simply not enough. While it seems as though it's quite reliable and valid, there's not enough to go on at this point. We don't know if the population was correct. So more cohort studies need to be done. And then a systematic review would be awesome to really see if this can and should become an evidence-based practice. So while this is not ready to become evidence-based practice at this point, if it were, the Iowa model is one that is commonly used in hospitals to implement a new change. So the first thing you're going to do with an Iowa model is you're going to identify what the problem is. So potentially on a clinical floor, the nurses are going to say, I'm seeing a lot of these patients being diagnosed with post-stroke depression, and maybe this is something that we need to follow up on. Maybe we can help before it becomes bad. So they're going to identify the problem. Then next, they're going to look at it and say, is this a topic of priority? Is this something that we really need to focus on? Is this something of value for our patients? Is this going to affect a lot of our patients? Is this something we need to put in front of other things? If the answer is yes, then they're going to go ahead and form a team or a task force. This team is going to be multidisciplinary. They're going to discuss it. They're going to do research studies. They're going to check out other hospitals to see what they're doing. And in the end, is there going to be sufficient evidence that this is evidence-based practice and that we need to make a change? If they decide, yes, there is sufficient evidence, we need to make this change, they're going to go ahead and start a pilot program. Generally, this is done on just one unit. In this case, if this hospital has a stroke unit, that's going to be the best place to start it, dealing with that specific population. So they're going to start a pilot trial and do this for a period of time. Then they're going to go back and assess it. Did it work? Did it not work? What were the roadblocks? What needs changed? How can we fix things or make it easier? And then they're going to decide, is this an appropriate thing for adoption throughout our hospital? Is this something that we should do? If it is, they're going to go ahead and institute the change within the hospital and make it hospital-wide. If that goes well, then they can make it system-wide. So it's just a baby step approach at starting a new thing. That way any roadblocks that come up can be assessed in the beginning and fixed before making it a bigger deal. Evidence-based practice. We've been talking mostly about research on this end, but clinical expertise is a big part of that. The clinical care team is going to see a need and they're going to know what needs to be addressed. And then again, is this of patient value? Does this help our patients? Is this where we want to go with our patient care? And these three things really put together are what makes evidence-based practice. And we need to address all sides of that before making something a part of our healthcare system. Thank you so much for listening to my presentation. If you have any comments or questions, please feel free to leave them, and I will try to answer them as best I can. Thank you.